So welcome as you're joining us. We're really delighted to see you online today, and thank you very much for taking the time. We're just going to start in a moment. Helen, is that everyone so far?
Yeah, we've got I think people will kind of join as we go because I know obviously it's across lunchtime, but yeah, we've got a decent number now. So if you want to get started, Ruth, and if
Perfect.
people have got any questions or anything throughout the webinar, if you want to pop them into the chat box or into the Q&A box, we'll keep an eye on both of those and make sure that we pull them out and our speakers are aware of them. We're also recording the session today, so we'll make sure that everyone gets a copy of the recording afterwards as well. Thank you very much.
Perfect. Thank you, Helen. And welcome, everyone. We're really delighted. We put this project together, or this webinar, because we were hearing about funding challenges and we thought it would be a really interesting conversation to have. And I'll introduce our panel in a moment. I'm Ruth Evans, for those of you who don't know me, and I'm the founder of PEN, which was the Patient Experience Network, part of the PICA team now. So today we're focusing on unlocking funding for patient experience improvement. And we've got a really great webinar, well, we think it's great, planned for you today. But I guess the first question is, well, why this, why now? So we know that we keep hearing about really promising patient experience projects, but that they're struggling to find funding. And we know that sourcing grants and funding is really tricky. It can feel quite challenging and impenetrable at times. We also know that the world that we're in at the moment is under increasing financial constraint. And it seems that some people are better at finding or accessing funding than others. So what we wanted to do is create an opportunity for some people who have been successful, some people who've been perhaps less successful at times, and I include myself in that. We lost a really significant bid recently, but to share our experiences. And I saw a question about the slides. Yes, the slides and the recording will be shared afterwards. And we know at the heart of this is when we get it right, when we drive improvement in the experience, it's a win for everyone. It's a win for our patients, of course, because we're looking at improving the experience, but so often it's also a win for our people and for our organization. And so we really wanted to spend a bit of time thinking about, well, how can we support organizations, or what are the challenges around unlocking funding to improve the experience? So our session today is structured as you would expect, and we're aiming to finish at the latest by 2 o'clock. We'll obviously finish earlier if we have nothing else to say, but I suspect it'll be a full agenda. We're starting, as you can see, with a welcome and the purpose of the session. In a moment, we'll do some introductions and I'll hand over to the team to do their introductions. And then we will move into a panel discussion. So we have some questions that I will ask our panel, but please do ask your own questions as well. So as Helen said, please use the chat or the Q&A and we'll keep an eye on that. We may answer the question directly in the chat, or we may pause and ask the speakers the questions. And in fact, we may ask some questions of you because it may be that some of you have the answers already. We will then, after the panel session, where I'm more formally asking questions, pick up the questions that you've asked if we've not answered them already. And then we'll just start to wrap up with, well, what are the practical takeaways? What have we been hearing from today? Think about some next steps and reflections. And as I said, our goal is to close today at 2 o'clock latest. So moving forwards. Oops, I've just gone the wrong way. Before we go anywhere, some of you may not know PICA, so I just wanted to spend a couple of moments introducing PICA. So PICA is a not-for-profit, it's a charity that's been around for quite a few years, started in the US, but is now very much focused on PICA Europe. And our goal, or our ambition, if you like, is to influence, inspire, and empower. We want to influence policy and practice. We want to inspire the delivery of the highest quality of care, and we want to really empower and support people to be able to do the best they can and improve the experiences by effectively measuring and acting upon people's feedback. So PICA have done this with 8 PICA, Principles of Person-Centered Care. And I always think that's a bit of a tongue twister that we should all practice. So at the heart of everything that PICA do are their 8 principles of person-centered care, and you can see the principles here. They are on our website, so if you'd like to dig into any more of these principles in more detail, please do feel free to go to our website. But they're the principles that have been shown over time to be at the heart of person-centered care. So if we're going to deliver person-centered care and improve experiences, it'll be particularly around these 8 areas, and these have stood the test of time, the test of culture, and we're currently actually revisiting them to see whether they stand the test of digital. But these are the 8 principles of person-centered care, and they are, as I said, at the heart of pretty well everything that PICA does. And PICA, you may well know PICA, particularly because of its focus on driving improvement by measuring what matters. We run many of the national surveys and a lot of local surveys, but actually PICA do quite a few other things. And we are part of PICA, the Patient Experience or PICA Experience Network are now part of PICA, and we're within the community connecting communities to inspire excellence. So our role, if you like, is to put the spotlight on brilliance and to bring networks together and enable them to drive improvement together. But PICA also enable transformation through person-centered approaches. So we've got a suite of standards and maturity models, for example, where we can help you depending on where you are and where you want to get to. And we also support people to build capacity to grow person-centered practice. So through L&D or training and toolkits to really support people in their professions. So that's probably enough about PICA, I think, but if you do have questions, please do get in touch. At this point, though, I just wanted to wrap up with 2 of our speakers are winners of our Patient or PICA Experience Awards. And therefore, I felt I ought to just mention the awards because they're open tomorrow, interestingly enough. And these awards are the first and only awards programme to recognise best practice and patient experience very specifically across all facets of healthcare and social care, both in the UK and abroad. And our aim is to bring individuals and teams and organisations together to celebrate projects and programmes that are moving to improve the experience of care for all. So it's patients, family, carers, and of course, staff, our colleagues. So you'll be hearing from those speakers in a moment. Joining us today specifically, and I will hand over to them to introduce themselves in a moment, we have Kate, Laura, Archula, and then I'm chairing and Helen is making sure that everything runs smoothly. So you can see that Kate is a sister, a specialist sister from University Hospitals Plymouth. Laura is head of arts at Derby and Burton Hospitals Charity, and Archula is chief executive at New Tissue. You will find out more about each of those in a moment. And with that note, I would like to hand over to our speakers so that they can introduce themselves. So Kate, may I hand over to you, please?
Hello everyone, my name is Kate Tantum. I'm a specialist sister in ICU rehabilitation, and I'm going to be sharing with you just over the next 5 minutes or 4 minutes or so our experience of building our secret garden, which is a fresh air space for our intensive care patients. Next slide, please. So like every good project in the NHS, it starts with a patient experience. It starts with a patient who told us that we needed to do something better. So I work in intensive care, and this is the story of the gentleman who helped design our intensive care garden. So Andrew was working abroad when he became unwell and was then repatriated to us in the UK. So he became unwell abroad. He had a spinal cord injury, has a spinal cord injury, and we were supporting him with his recovery. I'm really pleased to say that his recovery goal was to get to his daughter's graduation, and there he is on his daughter's graduation day. But this is a man who described himself as an outdoor person. And prior to when Andrew was with us, he spent nearly 4 months in intensive care. We didn't have a fresh air space that our patients could get to easily. We had a courtyard that was down a lift and had no access to facilities. So it was very difficult for us to take our patients outside. And we know that anyone who's been in hospital for a long period of time, it has a significant impact on their mental health. So us as a team, we were trying really hard to create a fresh air space that would be suitable for our most vulnerable patients in the hospital. And Andrew very kindly supported us in creating that design. Next slide, please. So how did he do that? Well, he worked with us and the architects and the M&E teams and the design teams and the survey teams to come up with a intensive care bed space that has 2 bed spaces, in fact, in a room that allows, it's floor to ceiling glass on 2 walls, and we've got all the utilities that you'd have in an intensive care bed space. So that means that now our garden is able to offer neonatal, paediatric, adult critical care in a fresh air space. And we were very lucky to be awarded overall winner of PENA a couple of years ago, sharing our work. We are very proud to say we think we're the only neonatal centre who is offering neonatal palliation outside in a fresh air space, which is a really huge accomplishment for our teams, and also we know it has a significant impact on our patients and loved ones. Next slide, please. But what else do we do in our garden? Well, prior to our garden being built, we had to raise an awful lot of money. So our first budget started off, and when we started our garden, I took our chief executive to a disused courtyard where the weeds were as tall as we were. They were about 6'5", and I managed to get her to open the door to a courtyard. It was like, that's why it's called the secret garden, because the door had never been opened. So we went into this courtyard. It had massive, massive weeds. And I said, I really want to build this into a fresh air space for intensive care. And our first budget from the head of estates was £5,000. And then the chief exec said, no, that's not going to work. You're going to need at least 50. And then we got the quotes done and it was 250. And then COVID hit. And then we are very proud to say that we were one of the first centres in the UK to take ventilated COVID patients outside. So you can see the amount of PPE that we had on in this picture. And that's because this was pre-vaccination. Now, we knew that fresh air therapy was really important for our patients. We knew that our patients were having significant amounts of delirium related to being critically ill, and we knew that this would work for them. So we took them out despite the fact that this was a significant impact. So you've got 2 ventilated patients outside in the sun. But this was pre-vaccination, so all of us were wearing more PPE than is humanly possible. And as you can see, it was pretty darn hot. And you can see my colleague in the back with his arms crossed. He was not living his best life that April day. Next slide, please. So we started fundraising before COVID, and then we fundraised through COVID, which was a challenge, but was actually, COVID was a remarkable time, and it actually allowed us to be able to prove the impacts of fresh air space, and it shone a light into the challenges of our intensive care population. So our budget, remember, started off with 5, then 50, and ended up being over 700 because it was the steel crisis during COVID. So anyone knows who's done a big building project in a hospital, costs are more challenging than would ever have thought. However, we managed to do it, and we opened then in December of 2022, and the patient whose story led us through this opened the garden for us, and it was a remarkable day. And how did we raise the money? Well, we raised the money because Andrew was very, very supportive, and he allowed us to use his story in all of our fundraising campaigns, and he also allowed us to use it as a lever to be able to get NHS hospitals together, charities together, to be able to support us with a significant donation. Next slide, please. So what do we do in our garden? Well, we support patients with their rehabilitation goals. We do family reunions. We do normal functional activity, including gardening. We've got a vegetable patch. We also have a lot of parties, weddings, you name it. We do it in our garden, including staff events. We do active rehabilitation. We also support end-of-life care, as I said, for neonates, peds, adults, and general hospital patients. And we also use it as a space for staff support, staff resilience, staff appraisal, staff meetings. It really is a space that is used every day. And we have a booking system because it's now so well used, and I probably have between 4 and 8 patients a day going outside. And that's something that's irrespective of whether my team and I are in. This stuff has now become part of the culture embedded in our organisation, which is an amazing after effect, I think, that we didn't really anticipate. Next slide. So this is one of the stories of one of the parties we had. This is one of our patients in COVID, where in the picture on the left-hand side, that was the only way her daughters could come and see her, because it was COVID and we were only allowed to have relatives in fresh air spaces. But I'm super proud to say that not only did she see her daughters for that reunion, which was a good 2 months before the second one, all of her rehab was about holding her little grandson. And there she is holding her grandson. And that was just a few days before her 70th birthday and before she was discharged from intensive care after nearly 100 days with us. So our garden has really been used for a lot of parties. Next slide. What else do we do? Well, we're also massive proponents of animal assisted therapy. And I hope that these slides have demonstrated, if you can share patient stories and embedding patient stories in anything you're trying to create, actually you will be able to use them and support your patients to tell you exactly what that project means to them, exactly what that project will mean to the organisation, and how it will improve patient experience in hospital, and that will therefore have a significant impact on them and their loved ones as they move forward. Thank you very much.
Brilliant. Thank you, Kate. And I think we've already got a sense of the fundraising prowess there in terms of moving from £500,000 to £700,000. And one top tip already is really getting support of patients and enabling use of their stories. And we'll pick that theme up in a moment in the panel conversation as well, in terms of, well, how do we make money move? But before we do that, I'd like to hand over to our second panelist to do an introduction. And again, another award winner, I'd like to hand over to Laura Waters.
Thanks, Ruth. Hi, everybody. So yes, I'm Laura Waters. I'm Head of Arts at Derby and Burton Hospitals, and also Director of the National Arts and Hospitals Network. And as Ruth said, former winner of the Patient Experience Network Awards, which was actually an amazing experience to win that. And it was a very uplifting thing. And we'd love to submit again and hopefully win again another year. So I'm really pleased to be here today and share some of my experiences around fundraising projects which support patient experience. So the programme at Derby and Burton Hospitals has been running now for 20 years. And during that time, we have received, I was trying to sort of add up, hundreds of thousands of pounds funding for creative projects to support patient experience and staff wellbeing. And we've benefited thousands of patients and staff during that time. So as I introduce myself, I was just going to show you a few slides of our projects. So the arts programme delivers music and public art commissions, theatre workshops, heritage programme, basically every art form you can imagine and every way of delivering it. We try and do something for everyone. And over the past 20 years, we have become so much better at identifying the right solution to the right problem and even identifying the right problems in the first place. Next slide, please. And part of that is obviously getting funding to deliver the work. And now I would say we are working in a very embedded way across our 5 hospital sites. So my role sounds very creative, all about the arts, and it absolutely is that. But really at its heart, it's about improving patient experience and the staff experience in ways that are really meaningful and evidence-based. Next slide, please. And a way of enhancing the medical care in our hospitals. So we're enhancing and adding that medical care to create a more holistic approach to the healthcare. So that means I do spend a lot of my time working out how to fund ideas and how to turn the sort of good intentions of staff and patients into deliverable projects, and how to help teams access support they need to make a difference. Next slide, please. So we do receive a lot of requests from staff members who may have identified a problem or seen an opportunity. There might be something in their environment or a process or something that could genuinely improve the wellbeing. So we get these requests through. But then also the immediate problem is always, where are we going to get the money from? Or it's too hard to access the funding. So this is something we come across all the time. So the arts team really works hard to try and ensure that we can make these projects happen. Next slide, please. So in my role, I've had to develop some very practical skills for unlocking resources and funding. So there's a lot of work involved in navigating the internal routes in the hospital and looking at external grants as well as looking at charitable funds. There's a lot around building partnerships and really using the resources you've got in different ways and sort of stretching what resource we have. Next slide, please. So the arts programme sits across many departments and areas of the hospital. So we work very closely with patient experience and with estates and staff wellbeing teams, and a lot of community engagement as well. So we collaborate with lots of people who have lots of brilliant ideas, but generally have limited time. So staff have these sort of, oh, we really want to make a difference, but they don't have the time or the budget, and they've got, huge operational pressures. So that's where we can really help them to shape their ideas into fundable proposals across from, even just like small enhancements. We might just put some pictures up, or we might do a really large, ambitious interior design project. So along the way, with all the work that I've done, I've sort of learned what makes a good funding application, particularly in terms of the hospital charity, and also what doesn't work. And there's, how to write a bid that really sort of cuts through, and how to also keep things realistic. It's very easy to have pie in the sky ideas and to sort of end up with something that is really difficult to manage. So it's got to be work that can actually be delivered as well. Next slide, please. So my sort of main point, I think, is that really you don't need to have sort of specialist language or special skills to get project funded, but it's really important that you do have evidence of real need and a way to demonstrate that impact. And it's got to be realistic and achievable. The patient story is absolutely key, lived experience, as Kate demonstrated really nicely, from generating those sort of first ideas right through to delivery and evaluation. I think I have one more slide. So I'm going to share with you my resources. So I sort of have some go-to resources that I use. I'm going to put some links in the chat for you. And these are the Creative Health Quality Framework, Creative and Credible Evaluation Tools, and we've got the National Arts and Hospitals Network. We've got a whole suite of materials on guidance on how to develop and deliver Arts in Hospitals programmes. So that's a fantastic resource. And also the Sensing Spaces of Hospitals Toolkit. So those are all my resources that I'm going to share links with you in the chat today. I look forward to the discussion. Thanks very much, Ruth.
Fabulous. Thank you so much, Laura. So two quite different projects, but and two different funding needs, if you like. But again, we've already got a top tip, which is around finding ways to evidence the potential impact. And it may be actually other examples of impact that we're using, and keeping it realistic and workable. And thank you for sharing those links. So our third panelist I'd like to introduce is Archila from New Tissue. So Archila, may I hand over to you too, please?
Thank you, Ruth. Thank you. Good afternoon, everyone. My name is Archila, and this is the only slide I have. Now I feel bad that I didn't prepare some slides compared to everybody else. So I'm coming from a relatively different angle with regards to funding. So with New Tissue, we are looking at, our goal really is to provide patients with experience in having a good experience in rapidly recovering from wounds and conditions like lymphedema that are associated with wounds. So we use three technology pillars to address this: materials, electronics, and digital technologies, to help patients experience the journey of recovering from a wound, and also to prevent bad experience in getting a wound to a worse condition. And also with regards to lymphedema, how can they manage the conditions of lymphedema without having to make it a dramatic event in terms of managing it and making it a daily sort of a life routine with the technology. So these are the slide is about, they are the technology developments, the innovations, but they are at different stages. So the most mature at this stage is our digital platform that connects patients and providers. And I reached out to PICA some time ago to be able to get more feedback from patients in terms of engaging them on our platform, and then that's one part of it. So and considering this is our approach to this is very much innovative, and a lot of development stages need to be navigated. We need to navigate a lot of stages at this stage. The only product that's out at the moment is the digital platform. So that's ready for patients to engage, but even everything else, all of the other innovations, they came from patients. So we came across patients needing various sort of technology needs and sort of evolved from there, really. So all of our developments centering patient experience. But it's one thing to come up with the idea of, okay, maybe this is something we can do to address a sort of a common problem with the patients experiencing, but then to develop a technology that's ready for patients to take up is not a trivial a challenge. So it takes a lot of organizing, sort of reaching out to patients and sort of teams, building the products, and then most importantly, why I'm here today to speak about my experience with funding. And so ideas are great, and we could have prototypes and things, but to actually get to the product to be released, you have to have a lot of funding. And I've managed to do a lot with competitive grant funding. And prior to New Tissue, I was an academic and worked in, and also I didn't think I told Ruth about, but I worked in research organizations actually from the other side of evaluating bids for a little while. So I was a portfolio manager, which means sort of with a group or with a team, we review the grants that's come through and sort of allocate scores, etc. The scores allocated from the referee, so putting into sort of ordered ways. And so I've had experience with that prior to New Tissue, and also for about 6-7 years, in the academia, I wrote grants, and some of them, which my name is not included, but I've had a lot of experience in doing successful bids. So yeah, so what shall I say? That's the introduction, but I'll think I'll come to any specific questions. But overall, with New Tissue, yeah, so it's our focus is to how can we get good experience for patients recovering from wounds, to recover from wounds, and making sure that they don't get a bad experience in making it worse, really.
Brilliant. Thank you, Archila. So I think we've got 3 very different speakers, as you've heard, with 3 very different perspectives on unlocking funding. And before we start the panel conversation, I wanted to just share with you some thoughts on the funding landscape. So I did a bit of research. I talked with all of our speakers and with various other people, and I'm sure you've got other funding routes. And I think one of our goals at the end of today is to share with you a funding resource, if you like, a bit of a toolkit. So in there we'll be including the different sources of funding that we've identified both today and through our research and independent conversations. But kind of the first slide here, and you, again, you may know some of these, but some of them you may not have been fully aware of. And it's what we're trying to do is just kind of build the depth of understanding about the opportunity that's out there. So obviously one of the first places to go will be internal organizational funding. So that might be improvement or innovation funds that your organization has. It could be program experience budgets, etc. It could be particular directorate or departmental budgets. Then, of course, there's hospital charitable funds. And I think many of you will have a trust charity or some kind of charitable foundation that's linked to your organization where you can go and bid for the money. So it can be a great source. And we heard that as the start point for, I think, a couple of the projects that you heard already about. There are separate and independently condition specific charities, and we know that, for example, Macmillan do a lot of work around supporting charity cancer. We see quite a lot of examples in our best practice. As part of the Penn Awards, people put a submission of their work, and in those submissions we get a really good sense of where the funding has come from in some of the submissions. So for many, it's been working alongside in partnership, and I think Laura mentioned building those partnerships early. Whether you know you need the money or not, it's often easier when you've got an established partnership. So making sure that you've connected with perhaps condition-specific charities. And there's also very local community and partnership funding. So sometimes there will be community foundations or partnering with voluntary sector organisations or local charity and wellbeing initiatives. So these are more of the kind of the more local opportunities that you may or may not have tapped into. But on the next slide, we then have perhaps and sometimes it's kind of the size of the pot will depend on the money that you require will depend on where you need to go. So for perhaps larger pots of money or larger needs, like perhaps the 700,000 that Kate needed, some of those more local organisations may not be able to address that need, although they could perhaps build up to it. But then you've got system level funding, so maybe it's the ICCS or regional transformational quality improvement programs. There's national grants available, and I noticed, and I don't know whether I should say this, but the Burdett grant is back open. It was closed all of last year, I think. But you've got philanthropic foundations, and we're, as I said, we're starting to collate lists of organisations that fall within each of these categories, and we will be sharing that back out with you. So there's the Q Foundation, for example, and the NIHR and all that, all of those organisations. And I think this is an area that perhaps isn't tapped into as much, but we do see it come through in our awards, are partnership and sponsorship opportunities. And we need to think about those carefully. I understand that. But organisations like John Lewis are very, very keen, for example, to support local initiatives as a national organisation. And then you'll see Morrison's or a whole range of different organisations, Amazon, for example, where they're very interested in collaborating. And it may be in funding or it may be in partnering with resource. And then, of course, joint initiatives with research or innovation organisations. And then, of course, there's the much wider international grants. And again, sometimes we may not think of those if it's a national project, but it could be of interest to some of the international grants when you're thinking perhaps of some of the wider or bigger projects. So some of the health foundations. And by the way, I would put pharmaceutical companies, which again, they do have money. Like all of us, they're a bit strapped for cash, but if there's a really aligned piece of work, then they may be a great place to go to in terms of the partnership or sponsorship opportunities. But there's global health organizations, for example, WHO, and international philanthropic funds that we might be able to access. And on the next slide, I've just pulled out a couple of examples, and I won't spend a lot of time on this, but if you are interested in our awards submissions, as I said, we get to hear about some of the partnerships that have happened, and I've just pulled out 4 interesting ones here because it might just give you a bit of stimulus for thinking. But if you'd like to go and have a look, all of our shortlisted submissions are on our website, and you can have a good old look around there if you like. But one that really struck a chord, and it is a while ago, but I found it fascinating, was that Alder Hey linked up with Everton. Everton obviously are a local football team, and they were interested in providing funding and support for a couple of activities that Alder Hey were keen to do around their children's work. And as part of that, they ended up with footballs in hospitals, which sounds like a terrible combination, but apparently it worked incredibly well. We heard very recently about Samaritans as a charity working with Liverpool University Hospitals, and that was a particular experience improvement of the emergency department, but it was a very powerful partnership that worked with Samaritans. And there's stacks of examples of tech partners supporting organizations and working with organizations through funding. And this particular one was with Digital Life Sciences, and you can see the lead at the bottom in that image there. And then one that, as I mentioned already, is John Lewis, but many of the big national retailers, for example, are really interested in partnering with local trusts and healthcare providers. And John Lewis is one that's notable and has come up in our awards historically. Perhaps doing exchanges, perhaps finding small funding opportunities, but just being a little bit more creative about the way that they're funding or partnering. So just a couple of examples as food for thought. So I'm going to ask Helen to take the slides off in a moment because we're now going to go into the panel discussion. And I'm just going to check if there's anything in chat before I move on and see if there were any questions.
We've not got anything currently, Ruth.
Okay. So please do let us have questions. And also, if you've got a brilliant resource that you feel could be part of this kind of toolkit of things that we're going to share, please do let us have that, or an organisation that you think would be interesting to add to the list. So let's move on to asking our panel some questions. And the first one is kind of like a really broad question. I'm going to come to Kate first, because you found £700,000, and I'm sure that is only part of the puzzle because you're continuing to do transformation. What did you find made the money move? What was it that caught people's funders' eye?
It's a really good question, Ruth, and it's not a question that probably has one answer. I think possibly the thing that I have found that has been most useful for me in my career of trying to get things done in the NHS and liberate action from people is I like to think of it as a trilogy, like the holy trilogy of getting stuff done. And one element of that is the importance of having a very clear patient narrative, because if you've got a very clear patient narrative, you're able to really support the people you're petitioning to have a narrative that they can relate to, that then leads on to a thoughts, feelings and actions. So I try, and whenever I'm talking to anyone about starting a project or trying to get something done for a project, it's about making somebody feel something. So I unapologetically use a patient story that is deliberately going to evoke an emotion, because I think if you can evoke an emotion, then you can evoke a reaction and some action. And sometimes action and a catalyst for action is something you need. The second element of my holy trilogy of getting stuff done is about finding the right evidence. So I'm a research nurse. I'm an intensive care nurse. I'm a research nurse. I'm also doing a PhD in the work that we've used in the garden, because I think if you can layer in the evidence base and layer in the national data and the international data that proves that the thing you're trying to do is going to make a difference to a population of people, however the metrics of that success is measured, is really important. So you've got the patient experience and making somebody feel something. You've got some evidence base that proves that the thing that you're trying to do is going to make a difference. And the final thing is understanding the economics of the situation that you're working within. So I like to talk about the economics, talk about how the thing that I'm trying to do is going to be making a difference to the organisation economically, because we are naive, aren't we, as a group of professionals, if we think that the NHS is not cash strapped. Everyone is going to have problems in it. Everyone is going to be competing for the same amount of money. So those are my three top tips. Patient experience, thoughts, feelings and actions, make somebody feel something. Then you've got the financial element of what is the intervention that you're going to do going to make a difference to that population or the wider population in the hospital. And the final thing is making sure you're layering in that evidence base. So it's the holy trilogy, I like to call it.
Thank you. And building on that, Archana, I'm interested because I know you talked about your actually three perspectives of funding. I'm interested in what is kind of structures a persuasive bid in terms of making money move. So what are your thoughts there?
Firstly, I'm speaking about this with not as a sort of a advice, but from my experience, so positive and negative, both. Generally, I like to structure an argument of the need and sort of an innovation. There's an idea that's not explored, and how that idea could make an impact to the pain point. I think Kate referred to sort of the problem base, and how that could impact a given sort of a scenario and also a wider ecosystem. So that's generally the approach, but there's no one way to say. And the question about, and this is the structure I generally use, but it's been successful and unsuccessful, so I don't know whether it's absolutely the case. And you see when you evaluate bids also from applicants that there could be very competitive ones, but then it depends on sort of who makes the best argument in terms of convincing that their background and their technology base is giving the required solution to that given problem. So it depends on, yeah, there's so many factors. You can do a really brilliant structure, but it depends on other factors as well. So that's generally what I try to do.
And I think actually you've kind of stressed something that I should have stressed at the beginning, which is I think we've all been successful, but we've all been unsuccessful. So we don't have all of the answers, but sometimes it's just knowing that other people aren't successful as well can be quite a powerful piece of information. But how do we dust ourselves off? So Archer, I'm really interested, perhaps we'll come to that later, is how do you dust yourself off and pick up again once you've had you've invested a lot of energy? But that's a question for a moment, because I'd just like to come to Laura with the same question on your thoughts. And again, you were talking about the fact that you've written or been part of quite a large range of grants and requests for funding. So what are your tips, or what are your thoughts about what makes money move?
Yes, I think, I mean, we've already talked about the fact it needs to be evidence-based, and I think what's really important is that you actually do that consultation and really understand what's needed in the space, because we do get a lot of requests for work, and then when you actually go and do a consultation in the space, you'll find out that actually this isn't quite what's needed. So from an arts project perspective, we get a lot of teams will come to us and say, oh, we really would like a mural in our space. We need some artwork to brighten it up. And so what we're doing now is going down and doing full consultations on, we use the Sensing Space of Healthcare Toolkit, which is brilliant, which looks at actually what is going on in that space and what are the sensory needs of the people here, because sometimes the staff may think that a mural will help, but actually what we discover is that the real problem going on, there may be something around staff morale or staff absence, and so we're looking at actually how can we support staff well-being, and that might not be about a mural, and it might be something completely different to what you've initially thought the problem was. So there's something about really dig deep as to why you want to improve the experience, what is actually causing the problems, and so I say there are tools out there, and I think it's about understanding. If you're going to look at getting trust or charitable funding, it's about understanding what the trust or charity's priorities are and which patient groups are they looking at, where are the hotspots in the trust. I mean, so if you've got data coming from there, that can also help support your idea. There's something around the demonstrating the benefit in terms of cost saving as well. If you can talk about how things can be streamlined or made more efficient, or you're saving time, these are all things that will absolutely prick up the ears of your NHS and the charity. Knowing your costs is really crucial. I mean, the costs can really spiral, so it's about really getting a handle on those to begin with. If you go to a funder and say, you know, I've got all these quotes, I know how much it's going to cost, I put contingency in, and you really understand what the finances are, that really helps as well. And I think the other thing is about understanding who will fund what. So it's really about choosing your funder appropriate to your project, and I think there's something around, don't try and sort of crowbar your project into the funder's priorities. So stick to what you know you have to do. You've got your project, this is what you need to do. Find the funder that suits it. And that's, I think, a really good way of getting successful funding. And then finally, it's the evaluation. Show how you're going to demonstrate the impact. Have some sort of method to evaluate and do before and after, so you can really share with your funders what you've been able to achieve through the project. And that's how you can then get repeat funding for the legacy work as well.
Thank you. So really kind of building on Archer's point about being clear about the pain point, and is it the right pain point, and are we addressing the right issue, and then kind of also building on really understanding what matters to the funder, and addressing those, because I think sometimes, and I know when we've been involved in reviewing grants, because as part of PEN we were also involved, people didn't answer the questions, and actually we need to just really pay attention to the question and make sure we're answering those fully, which I think, Archer, you were saying is sometimes you win, sometimes you lose, but you need to really be thinking about, well, let's answer the questions properly. And then Laura, knowing your costs, and all of, so some top tips, and I'll draw these out towards the end, but just building on that, well, what therefore makes a proposal credible? We've talked about the fact that we need to understand our finances, and we need to understand our funder, but what else makes the funder the proposal credible? And Laura, I'll come back to you to just build on that. So
Yeah.
yeah, how do we do that?
So, I mean, I spoke about gathering the evidence, and I think as part of gathering the evidence, if you're a member of staff in a unit and you see what the problem is, and you've done a bit of, you're talking to the patients, you've done a bit of consultation, you are the expert in that area. You understand what's happening in that space. So use your own voice, be really authentic. So one of the most effective funding applications I saw in our hospital was our spinal unit came to request money from the charity to put some TV sort of on the ceilings for patients. And the whole presentation, they used the image of a ceiling in the spinal unit to show what it looked like for somebody on flat bed rest for 6 weeks. And it was the most powerful thing. I think it was the most simple photograph of the ceiling, but just the story wrapped around that. I thought that was a real sort of passionate plea for this is what's happening. So it's about using plain language, use your own voice, give a really clear understanding of what the problem is and how you're going to solve it, and all the as much detail as you can around how you're going to do that. You've got to make the funder feel as if you're a safe pair of hands. So talk to them about what they want to see. What sort of language does your funder use? So use your own language, but also borrow a bit of language from your funder so you can bridge that gap. And it's about having the facts at your fingertips. It's about making sure that you've really thought everything through. So if you know that if you show that it's a well thought through proposal, knowing who is going to deliver the work, how it's going to be delivered, how it's going to be evaluated, as much detail as possible. Because actually a lot of projects they fail or they don't get funding because the details haven't been thought through. So it's around the project management and also the legacy. Think about how, what's going to happen after the project's finished. How are you going to maintain the space? How are you going to keep it being used?
I thought that was really interesting about using the language. So it's trying to be authentic and use your own language, but being mindful. And I think particularly when you're talking with people whose world is finance, we do have to reflect that in our language. And you're saying find a way to create both.
Yes.
Building
actually,
on that, Kate,
if I may,
sorry, yeah.
So I was going to say, if I may just talk about a sort of an example of that. So in the arts world, we keep talking about, it brings joy and it brings an increased sense of well-being and improves experience. But actually, when I'm talking to NHS colleagues, they are much more likely to sit up and listen if I say that there's also the theory that this improved well-being will then relate into reduced use of analgesics or a shorter stay length or improved staff morale. So it's about just translating some of the things that you're talking about so your funder can understand how it's going to match their criteria.
Right, and in a language that will help them achieve their goals as well then.
Yeah.
Really interesting. So Kate, coming on to you to build on that, any additional thoughts on in terms of what makes a proposal credible?
I think exactly as Laura said, it's about the outcome measure. So how are you going to measure the success of the project? And you link the success of the project into the initial aims that you had for the project. And so when you're pitching for the funding, you need to say, we think this is going to do X, Y, and Z. And then you need to prove how you're going to measure that it's done X, Y, and Z, because then that allows you to really prove and really highlight the impact of what you're trying to do. Because then that is an impact not just seen for that population, but it will probably be a wider impact as well. An example from our practice is that we built this garden with just thinking we were going to use it for our intensive care patients, and now it's used across the whole organisation for any patient, any loved one, any member of staff. And had you told me right at the beginning, oh, your garden's going to be used for neonatal palliation, I would have gone, I don't think so, but now it is. So I think sometimes there's going to be expected outcomes. So you can measure, just as Laura said, you can measure analgesia, you can measure length of stay, you can measure patient satisfaction, you can measure mental health outcomes if it's related to or physical outcomes. So I think having an outcome measure, having a measure of your success is really important, and building that into your proposal, because that means you're serious. That means the funder's going to sit up and go, right, this person has got a plan. And I think it's that planning bit of if you can bring the patient experience, the plan, some data and some financial understanding of the impact, just not for you, but for the rest of the organisation, that's going to be really, 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 really supportive. But that language stuff is really important. And it can be very intimidating, actually, the language sometimes, that you might feel as a clinician, you don't know the right words, or you don't know the right approach, or you don't know how to write write the grant or the report in the right way, but I would really encourage people to speak to the network of your organization. So there will be people in the organization, in your charities teams, in your estates teams, in your finance teams, who absolutely want to support you to be able to improve patient experience, because no one works in the NHS for the money, the parking, or the uniform. They work there because they fundamentally care about people and making it better. And the NHS's largest asset are its people. So if we can support our people, our staff and our colleagues and each other to do something amazing for our patients, the impact is not just on a small population, it's always much wider. So I think outcome measures, so measuring your success and including that as part of a grant proposal, is such an important thing. And then through that, you can demonstrate real patient benefit. And it doesn't have to be a hard and fast quantitative metric. It doesn't have to be a number. It can just be sharing a patient's experience. Because when I share the feedback from loved ones of neonatal babies who passed outside, it is utterly, utterly, utterly heartbreaking and beautiful and powerful. So your feedback from your service users or from your stakeholders doesn't always have to be hard and fast numbers.
Indeed. And just building on that, Archla, any other thoughts? And I know you talked about clear problem definition, but anything else that really makes a proposal feel credible?
Yeah, I think Laura and Kate, they've covered everything, I think, but maybe I can add a little bit. So with regards to a little bit more technology-based proposal, so you're very much in the, as in Kate and Laura, they're very much in with patients sort of at this stage. So if there are proposals that that need a little bit more development but still going towards patient experience, then there is something called technology readiness. So how ready are you for this to be ready for the patient? So that's something you ought to be looking at, because some funders would say we are only looking at if your technology is ready at 4 or 5. They have a scale. So then if your technology is much more advanced, like you're already working with neonates and patients, then that's not what you're looking at. So then you're a little bit more advanced. Then at the same time, if your technology is a little bit more earlier, then so you have to just find that. But then if you have the idea, maybe you're developing, because one idea can be in different forms, right? So you might want to see where you are and sort of tailor it to that. And with regards to credibility, I think sometimes, I mean, at least in my experience, we put things that we have a background of what we are working and how that could be evolved to address another patient experience. So, but at times, sort of, you are so much in your project, and then there's a question: have I explained it very well, the background and the experience that we have? So that's quite important to sort of explain, because you think everybody, like maybe you know what you're doing, but the reader, the evaluator, wouldn't know whether you know how much you progressed and so on. So you might want to really show this is more for technology-based sort of early stage possibility. That's not in the market.
Yeah, but I think you raised such an interesting thing, because we actually see that in the PEN Awards as well. People so involved in their part of the world that they don't remember that this is something that no one else is that familiar with. So it's stepping back out and really making it really, really simple and not falling into assumptions, because you just know that to be true for your own part of the process, but it's remembering that others don't. And I think that's what you've described, Archla, is kind of just stepping back and remembering they're not in your world. You need to be simplifying it, avoiding jargon, and really making it crystal clear what it is you're asking for. So perfect, thank you. We haven't mentioned it yet, but I think we have to. And Archla, I am going to come with you first, because I know that you've used AI quite a lot for bid writing, but equally I know that Laura and Kate have some thoughts on this as well. But what about AI and bid writing? We're getting into this world where all of complaints are being written by AI, and it's a tricky world. So what are your thoughts on Where does AI help, and what are the risks?
Yeah, so I think of it in two separate ways. One is the help for the bid writer. The other one is how the evaluator might want to be looking at it. So I find it really helpful for the reasons I was saying. Sort of, I think everybody mentioned about answering the question and whether you're addressing the scope and things like that. So sometimes when you write the proposal, then you're so much in it. So sometimes you can train the AI, not train actually, so that you can instruct the model to say, can you check whether I have addressed all of these questions? And you would just get a good answer as in a very thorough critical evaluator. So you make sure that you've done the optimal bid in the best form. So I think that's quite helpful. The other, from the point of the grant evaluators, considering that everybody's now using, not in the sort of, if they use AI to sort of actually write the bid, and so what is the point of marking for how beautiful you have written it, as in sort of how lovely that it's formatted, or what's the point? So you shouldn't. And now there's because I've written grants and I've been marked down because it's not sort of structured correctly, in the sense it's not the content, but it's not sort of structured okay, and things like that. So is there a point in doing that? Because I think considering everyone's using AI, it's not to stop them, but there should be other parameters, I think, that could be included to evaluate. So like the background of your proposal, what have you done to approach with the proposal? So what's your qualification, in the sense, not your degree qualification, what are you presenting? What is it that you can make it an experience for the patients, and how ready are you? Sort of things that you can maybe brought into the evaluation. Yeah, I think there's a tendency for people to use AI just writing, and then it becomes very generic. So I think, and then that should be picked up as well. So the evaluators should become more aware of the grant writing help they get, not when it's not authentic. So you shouldn't have sort of I can only say, like, not the way you write, but it's the content of what you present. It should be more of what you should be awarded for, I think.
So a really useful top tip about checking what's missing, but remembering that we can lose our authenticity potentially when we're using AI. And I know that Kate, you've got some thoughts on this as well. So
I think, yeah, thank you. I think AI can be really useful if you're wanting to get so if you're new to an area, or you might not be you might have a different academic background. Sometimes AI can be useful to support you with an academic literature search. There's lots of literature searching tools that are available online to support an academic understanding of where the evidence base is. So we talked right at the beginning about making sure the trilogy of things to get stuff done is an understanding of the evidence base. And I think sometimes you can worry that you don't know all the evidence base, and you think, oh my goodness, I'm never going to know as much about this as I need to. And I think that you can use AI, if you're using it appropriately, to help you search the evidence base. So there are literature searching tools you can use. For example, there's a free tool called Research Rabbit that you can find a paper potentially, or find a source that is really useful, and then you can plug it into it, and then it will map all the other bits of literature that have used that paper. Now, that's not giving you the answers from what's in the paper, but what that is doing is it's showing you other people that have cited similar work. Now, clearly your role is to look at those things and go, actually, relevant, not relevant, relevant, not relevant. But actually, there are now AI tools that you can use to support you with the evidence building element, because it might not be something you're used to. And I know that Ruth's going to circulate some of the, there are lots of academic institutions. If you've ever done an academic course in a university, they all have good and ethical use of AI guidance on their website. So I would always refer people to those. I think it's really important to be using it sensibly, pragmatically, and appropriately, and never to think that it's going to give you all the answers, and never to think you can just put a question in AI and then submit that, because that's clearly not going to work. This is about you as a healthcare or you as a professional using your understanding of the problem and the topic, but using AI to help supplement, support, but also help you to navigate some of the difficult areas. I think it's really important that you are encouraging anyone who's writing or supporting writing bids for things to be very careful with the language that you use, because I work academically and do marking, and it's really easy to see somebody who's looking at things when you're used to looking at bits of people's work that you can see AI instantly. And I think sometimes that can be really challenging for the reader and challenging for the person who's trying to appraise the work. So I think people think sometimes, oh, if I just put something into ChatGPT, it'll give me the exact answer, and it won't. It will give you an answer, but that answer might be old and it might be wrong, and it needs you as a sensible, articulate, bright individual to be able to unpick it a bit. But I know that we'll be producing, or we'll be sharing some of the resources that we found that might be useful for people if understanding the evidence base is a skill that they're getting back to.
Perfect, thank you. And Laura, I know that you see a few with AI, I think you were describing, but what are your thoughts?
Yeah, I mean, I would only ever use AI, particularly at the moment, to just clean up an application. I think the hard work has still got to be done in the consultation, identifying the problem, and really making sure that what you are trying to do is the right thing, and you can't do that through AI. You've got to use your own expertise and knowledge to do that. And also, you know, if it's your project and your funding bid, you've got to let your voice and your stories come through, and AI will not generate that for you. But what it can do is just clean up and help with an application in terms of the sort of the structure, the format, the spelling, the grammar, things like that. I would only ever use it on that sort of quite low sort of admin basis. I think what Kate's saying about getting somebody, helping it to get some research to back up what you want to do is also really, really valid. I think you can also use it to generate timelines for your project, and maybe even develop, if you're doing some consultation evaluation, you could use it to generate questions and ideas around how you're going to evaluate. But I think for the actual the main body of what you are putting into a funding bid, it has to be your own voice and your own ideas, your own stories, based on full consultation. So it doesn't take away from that bit of initial work, unfortunately.
So very much an enabler,
yes,
when used wisely. Thank you. And I know AI is a hot topic, and we'll come on to your questions in a moment. But before we hand over to our audience to ask the questions, if anyone's on the call and is thinking that they've got to write a bid tomorrow, what should they prioritize, or what should they stop doing? So just one fast top tip from you of everything that we've described. I'm going to come to Kate first, then Laura, then Archana.
Story, patient voice.
Okay.
So I would say base it on actual need and not what you think is required. Really do that work to dig deep as to whether you're doing the right thing.
Yeah.
Create a list of background evidence why you are the person to put this bid forward, and how you can actually deliver on the proposal.
Okay, brilliant. Thank you. Thank you. So thank you very much. I think we've already started to cross some top tips, and as I said, I will start to pull that together in a moment when we wrap up. But I'm just going to go over to Helen and see if we have any questions. I've seen a few pinging in.
Yeah, there's a few. Someone's asked, would you, I think it was when you were talking initially, Kate, about like impact and things like that. So they've asked, would you be transparent about the overall impact of funding on the organisation as opposed to just a specific project? Or is it better to be project specific, or is it better to then bring in the wider organisation impacts as well?
I think you can do both, and I think good projects often do both, because what you want to prove is that you are creating a project that is going to be an overall force for good for the organisation. Because if you can prove that it's going to be an overall force for good for the organisation as well as just for your population, then you're much more likely to get funding. So I think if you can find benefit and you can identify a population or populations who will be impacted by the work that you are doing, you should absolutely hammer that home, because I think you can never underestimate the more stakeholder, the more people you can convince that you're going to make a difference, the more likely you are to get the money.
Indeed. So do both is the guidance.
And we've got, oh, sorry, I was just going to ask the next question.
Yep.
Don't want to interrupt.
No, go for it, Helen.
So we've got another one that kind of references kind of academic, accessing academic materials. So this person has struggled with access to academic materials. So once you're not a student, it can be quite difficult to access academic books. You said, are there any thoughts in terms of how to access academic materials once you're out of that kind of education realm? And also, is there any AI tools in particular that might be good for like literature searches?
So I was going to share with Ruth, and I think I already have shared a selection of the best AI tools that I think are available free online for anyone. You don't have to have any affiliation to an academic university to use any of these tools. But I think it needs to come with the caveat that if you're learning to use an AI tool, it's as good as you are. So in the same way that the prompt you put in will dictate what you get out, the same is true of all of these literature searching tools. And these tools do take some time to be able to use. So we'll put together a selection of a few of them, but the ones that I can name off the top of my head are ResearchRabbit and LitMaps. They're both very good ones that I've used recently that are useful because they build a picture, and I think sometimes a picture is a really great way of then mapping what you have to do next. And it's also a picture over a timeline, and you can change the different information visualization aspects.
And Laura, have you got something to add to that?
Yeah, only that obviously if you are a member of the if you work for the NHS, your hospital, if there's a library or there's a research department, reach out to them because they will do literature reviews for you, and they can also get hold of books and journals, and they if you've got a hospital library research, then it is one place you can look at. If you don't work for the NHS, then I think you are at the mercy of looking at things online, and hopefully those resources that Kate just shared will be good. But I totally appreciate that it's difficult because all the academic literature is kind of locked down unless you have academic or email addresses and can get into the system. It is tricky.
And also, I think sometimes people think that getting support for a literature search means you haven't done it yourself, means it's not your, and I would absolutely stress that that's not the case. So it's when you're trying to do something, what you need to do is find the network of people who can support you to do that, because no one can be an expert in everything. So I think don't feel bad if you're getting support from your library or from colleagues or from other places to be able to get you the data that you need to present the grant that you want to. I think it's about using your network and being unashamed and unabashed with asking for support from as many different people as you can to get the outcome that you want for your patients and for the population. So don't feel bad asking for help is the other thing I would say. And that took me a long time before I was like, oh my goodness, I really should know the answer to this question. There's no stupid question. The stupid question is the question you don't ask.
And I think, add to that, oh, sorry, Archula, go for it.
When you ask for help when it comes to grant writing, make sure that it doesn't come with a huge cost. That's very important, and read the contracts if you were to work commercially for support. That's so important.
Yeah, great point. So if you are using and there are and different organizations will take different routes as they do with everything, but if you are, as Archula said, if you are using a more commercial or a professional bid writer, just make sure that you're checking the small print. But in there, and I think it was a really interesting point that you've all kind of flagged, it's okay to ask for help, and I think sometimes we forget that. And actually, one of the things that you might find is that the more successful people are willing to ask, not more successful, but that they'll have gone and made the connections, got the partnerships, asked the silly questions, so they're very well prepared and for the actual grant preparation itself. Any other questions from our audience? I did notice that there was one comment rather than a question, but I thought you might like to see it if you haven't heard it already. But very great to see that you're using the PDSA approach to your projects. And I just wondered if there was anything worth adding. Is that part of, is that a top tip that we should have?
I think that's something that is talked about quite a lot in NHS circles, PDSA approach to things. So I'm very glad that that was sort of recognised. It wasn't something that I haven't sort of overtly thought that's what we're doing, but maybe this is just how we just work automatically without even thinking now. But it's just a really robust way of having this sort of working around this circle to make sure that you are constantly improving and evaluating what you're doing. And actually one of the frameworks I mentioned, the Creative Health Quality Framework, that has a similar kind of cycle for improvement to say that actually once you've done your study, reflect on what you've done, how might you improve it, and how do you what's the next iteration, how do we make things even better when we go around again. And I think any part of doing these sorts of projects is trying to make improvements. So it's a really good sort of framework to base work around. I'm sure Kate's come across PDSA as well.
Good habit. And Bill's actually got his hand up, so he might want to add to that comment.
Well, introduce myself. I'm actually a voluntary member of a patient participation panel. So I've actually helped this trust actually do some quality improvement. But the other comment I'd like to share with you is another activity that I get involved with is co-design. So what you're actually doing there is between in preparing the bid and targeting the potential funder, you're actually embarking on what we would call a co-design project. So there's disciplines there, if you don't know about, take that and it's more strength to your elbow. But all in all, enjoyed the content and a lot of things to take back to my own work. Thank you.
Perfect. Thank you, Bill. Any other questions from our panel, for our panel, before we start to wrap up what we've been hearing? Just see if there's any other questions.
I think we're good to start summarising, Ruth.
Okay, perfect. Well then, what I'd like to do is just pull together my thoughts about what I've been hearing. And thank you so much to everyone who's joined us, but a particular thank you to our panelists today for sharing your thoughts and your time. What I have been hearing are our top tips. We started off with embedding patient stories. And we've heard that kind of going through the piece, and that being part of our Holy Trilogy is making sure that we've got the patient narrative so that people feel something and react and potentially take action. We also heard quite consistently about the ways of demonstrating potential impact. And if you haven't got direct examples, how do you find that and how do you get that evidence through the literature? And finding the right evidence is making sure that that really feels evidence-based. We spoke about keeping it realistic and workable, and actually keeping it simple, and where possible, almost starting to proactively create partnerships. So going back to the trilogy, we had the Holy Trilogy of the patient narrative, finding the right evidence, and making sure we're understanding the economics of the organisation that we're working with, so that kind of financial clarity. We talked about making sure that we're really clear that we understand what the need is, super clear about the pain point that we're addressing, and actually challenging whether that is the right issue, and consultation and that idea of co-creation perhaps being built in there. Really understanding the focus of the funder and making sure you've got the right funder. I think sometimes there is only one funding option, so we need to really understand what matters to them and work out how we can address that need. Knowing the details has come up consistently across the piece. And having a good plan, it really demonstrates that kind of eye for detail and that depth of thinking, and knowing your costs is a critical piece of that. Knowing who will fund what, I thought that was quite interesting, because actually it might be that we do have some options, and finding the funder that suits. And again, something that's just come through again and again is we want the evidence of the impact, but we really need to be thinking about that in terms of outcomes that matter. And matter to the people that we're appealing to, as well as to both the patients and our organisation and the wider organisation. We heard a little bit about when if we're not directly focusing on patients, well, what do we think about? And it's about technology readiness maybe, and thinking about making sure we've got the language, because sometimes funding can be early upstream, and really thinking about when we're using language, making sure that it's our language. Don't want to lose that. I love that idea of joy and well-being. That's important, but also that it needs to be in the language of the funder, but keeping our authenticity. So when we use AI, make sure that it's not an AI response. It still has to be our response, but use AI to check what's missing, check we're not being too generic, check that I always I love the fact now that nothing needs to have typos or grammar errors, because AI will spot them for you as long as you've told them to speak in English as opposed to American. But ultimately, 3 things: patient voice or story, what is the real need, and what is the evidence that we're going to make sure that we're going to share. What are we going to have the evidence of impact? So I hope I've covered everything. Helen, any final comments from our speakers, and then we'll move the slides on to our wrap up.
Someone had asked specifically about a pilot project, but I'm just I'm popping them a note now in the chat.
Thank you.
Yeah, so I think we're good to wrap up.
Speakers, any final comments? Anything I missed that, or anything you'd just like to reiterate before we wrap up finally?
I think I've just got one more thing I would like to say, and that is that your project, whatever your project is that you want to do, is something similar may have been done somewhere else before. So it's always worth reaching out to those people who have done other successful projects. People are usually very happy to talk about how they got funding, or how they ran the project, or any of the problems. So it's really, really worth reaching out. You may even get people to send you a copy of the funding bid they wrote, so you can start looking at what a successful funding bid looks like. So that would be my advice. And I think the pilot project, always good to do pilots, actually. That's a really good way of generating evidence for a much bigger project. Thank you.
And that's great thought. Thank you, Laura, because we also have a great set of resources, and what I love about our part of the world is that people are willing to share their experiences, and particularly where they've been successful or unsuccessful, so that you can learn from their experiences. Kate?
I would say there's a great Winston Churchill quote which I use on nearly every presentation, which is success is going from failure to failure without a loss of enthusiasm. Sometimes it can feel really hard, can't it? It can feel really hard getting anything meaningful done when you're managing all the different challenges that we all face. So I would also like to reiterate to everyone that if at first you're not successful, try again. Channel a bit of Winston, just keep going, and eventually you'll get there, because you will have learned all the lessons you need to be able to make the project a success at the end. So if you aren't successful, don't take that as a I'm terrible. Avoid the all or nothing thinking. Embrace the fact that every opportunity you get for feedback is a great opportunity. So just keep going is the thing I would say.
Thank you.
I'd like to add to what Kate said, that absolutely. So I'm here sort of with many unsuccessful outcomes, but still I sort of try again, and I'd like to think I'm indefatigable. So when just you have to, because it might not be that your proposal is really sound, but it might not be the right sort of the funding, or you just run out of funds because you ask a little bit more, and then it could be sort of, so you just have to that's what I like to do, but you sort of address all of the points that we discussed, but even if you do all of that, sometimes it might be the outcome that you didn't want, but that means you try again. So exactly like you said, yeah.
And a perfect wrap up. So it's that resilience to learn and continue. So following today's webinar, we will share the slides. We will be showing the whole recording, but we'll also be making extracts available over Patient Experience Week, which, if you didn't know it, is the week the last week of April, so it's the week that slightly tips into May, which is just a great week to celebrate everything that's working well in your organisation about the patient experience. We've talked about top tips. We'll be drawing those together, and linked in with that, we'll be pulling together resources that both Kate, Laura and Archer have shared, and sharing those back out to you. But I like to think of those as kind of emergent, because it could be that actually we've missed a couple of really great examples. So as you're finding resources, please do feel free to share things back with us, and we'll add them to our lists, and perhaps we'll put them on a shared space somewhere. I would like to say a massive thank you to everyone who joined us today, and a particular thank you to our speakers. Honestly, obviously, we couldn't do it without you, but I also can't think of 3 better speakers for today. So thank you so much for your time. And we will say thank you and goodbye. Thank you.
Thanks very much. That was really helpful.
Thank you, everyone.
I think we're